Hello, everyone. So we are continuing with clinical cases. We are actually starting with clinical cases for Mrcpch theory and science. Starting with respiratory section, I think it only has two chapters in it, and we will discuss it quickly, and then we will discuss serious. Starting off with chapter two. Wait. Uh, Together with persistent ways and 3-year-old girl Chloe presents with recurrent episodes of virus-induced wheeze. These began at the age of 2 years when she started a local nursery. Episodes occur with upper respiratory tract infection. They last for up to 5 days and occur more frequently in the winter period. She was given salbutamol by PG, by her GP. Sorry, it responds well to this given via spatial device. There is no response to antibiotics. In between episodes, she's completely well, no cough, these are difficult breathing, having symptoms, and she's growing normally. She has no allergies and no strict eczema or allergic rhinitis. There is no family respiratory. She's commenced on methodicast ventilator therapy. Patient is statement best describes mechanism of action metallic class, blocks the action leukotriene D4 in the lung, decreases the level of gamma interferon, increases the level of leukotriene D4, increases the level of phosphodiesterase B3, and inhibits CNS3, the following is not a risk factor for developing asthma at school age. Allergy dryness, breastfed infant, food allergies, obesity, and parental history of asthma. Let's stop here. Sorry, let's stop here for 5 seconds and you can see. Um, it's pretty easy and basic, and it blocks the action of leukotriene D4 in the lung, and it's which is said not risk factors. So it's breastfed infant by the age of 6 years. Nearly half of all children have had at least one episode of wheeze. Most people wheezing, preschool wheezing is associated with viral upper respiratory tract infection, which occur frequently in this age group. Asthma is less common. Most with early wheeze will have stopped wheezing by school age. It is probably helpful to divide children preschool wheeze into one of the two main phenotypes: episodic viral wheeze and multi-trigger wheeze. Although viral wheeze is the commonest cause of wheezing in this age group, a careful history examination is needed to rule out other causes of wheezing in infants and young children. Causes key clinical features diagnostic investigations in childhood wheeze. So causes are episodic viral wheeze, multi-trigger wheeze. Clinical features would be clear history of viral triggers, episodic multi-triggers, none needed if other causes excluded the history examination. Viral infection, bronchiolitis, coryza, belly crabs, and hyperinflation. Nasopharyngeal respiratory for immunofluorescence and PCR, which is the diagnostic investigation. In GERD, such as visual reflex disease, recurrent aspiration, vomiting, poor weight gain, recurrent chest infections, field study, bronchoscopy may show lipid macrophages, and contrast study. Inhaled foreign body, acute onset of symptoms is coughing and choking, sometimes focal. We chest X-ray, visual bronchoscopy. Cystic fibrosis, cough in first few weeks of life. Poor weight gain, symptomatic insufficient sweat test may have been under 5 by newborn screening. Primary dyskinesia, rhinorrhea from a young age. Recurrent media, chest X-ray to look for osteopathy representing 50% studies. Immune deficiency recurrence where persisting or unusual infections, hemoglobins, BNT cells, functional abnormalities, HIV test, cardiac disease, heart murmur, garapitin, tachycardia, hypertension, slow, flaps, chest X-ray, ECG, and echo. And post-infection bronchiolitis, a betrays history of previous viral infection, usually adenovirus, and high-resolution CT chest. Episodic iris is characterized by short episodic associated exclusively with codes upper respiratory tract infection between episodic research episodes are well asymptomatic. Most common causative agents rhino, RSV, and coronavirus, human meta, pneumovirus, parainfluenza, and influenza. Episodes are more common in the winter episodic viral wheeze, usually resolved by age of 6 years, but can continue or change into multiple trigger wheeze. Multi-trigger wheeze resembles atopic asthma and pollution, which is triggered not only by colds but also by non-viral triggers such as pets running around and cold weather. To overcome some of the limitations of single point in time description of wheezing episode and in childhood preschool wheeze can also be described retrospectively Retrospectively, as being transient, symptoms commence before 3 years and resolve by 6 years. Persistent symptoms continue beyond the age of 6, and late onset symptoms start after the age of 3. Transient wheezers are thought to be born with airflow obstruction, and whereas those with persistent wheeze, which may be episodic or multi-trigger, but more likely the latter, have normal lung function soon after birth but lose lung function in age 4 to 6 years. Liver obstruction in these occurs as a result of small to moderate pleural obstruction due to either inflammation as well as a bronchial obstruction. A cellular inflammatory exudate with eosinophils, neutrophils, lymphocytes, and mast cells can fill and obstruct the airways and induce epithelial damage. Helper T lymphocytes and other immune cells produce pro-inflammatory cytokines such as IL-4, IL-5, and IL-13. Thickening of the basal membrane has also been shown to occur, but less permanently frequently central and with severe asthma. Sodium viral B is a bronchodilator. Bronchial lavage is mostly neutrophilic and blood studies done during wheezy episodes show neutrophilic rather than eosinophilic activation. This contrasts with atopic asthma, in which the eosinophil dominates. It is therefore unsurprising that conventional asthma therapy is less likely to be helpful in this group. Treatment of episodic viruses is aimed at parental education, reducing cigarette smoke exposure, and use of short-acting beta-2 medicine when required. Beta-2 receptors are present and functional from infancy within the bronchioles. They act through activation of retinal cyclase and thus increases interstellar cyclic AMP, leading to relaxation of constricted bronchial smooth muscle. It has no effect on inflammation. No treatment has been found to be disease modifying in episode of these. And however, if the children are having frequent or particularly severe episode of IRVs, preventative therapy should be considered. Metallic acid has been shown in some studies to reduce the frequency of exacerbation by 30% and improve some metallic acid is cystenyl. Leukotriene receptor antagonist and blocks action of leukotriene D4 in the lungs and bronchial airways. Cystenyl, leukotriene C4, E4, and D4 are important mediator released by the bronchoconstrictor vesicle permeability and mucosegregation due to release of inflammatory mediators from alveolar macrophages, eosinophils, and mast cells. When Tenofovir blocks this action, it also has been reported to have some secondary anti-inflammatory properties, reducing neutrophil activation. Regular maintenance dose inhaled corticosteroids have not been shown to reduce hospital emissions or oral corticosteroid courses, insulin episodic IVs, but extreme trial may be considered in some children who do not respond to metallicas at their binding to glucocorticoid receptors and reducing their respiration. Multi-trigger reason preschool should be treated as atopic asthma in old children with a trial inhaled corticosteroids. In most children with episodic IVs, symptoms will have resolved as school age. Risk factors for asthma children include parental asthma, personal history of eczema, allergic rhinitis, food allergies, and sex, cigarette smoke exposure, low birth weight, obesity, and airway hyperreactivity. Being breastfed as a baby reduces this risk. Infection immunity allergy, know the epidemiology and natural history of atopic disease. And this is respiratory medicine. It's infection immunity and respiratory medicine has surgically pathological histological changes and the genetic environment in the etiology and understanding pharmacological agents commonly used in respiratory disease. So the secretary is a child with poorly controlled asthma. An 80-year-old Caucasian girl had been treated for asthma in the past 3 years by her GP with inhaled salbutamol, inhaled corticosteroid, blood meters on dry propionate 200 mics BD, and she is 8 years old. Good. Despite this, she has recently had a worsening of her symptoms and has been referred for a pediatric opinion. She is otherwise healthy apart from mild flexural eczema. There is no history of premature significant cellular infection as parametry. It's pre-bronchodilator experience post. Epigreen has gone to C5, later under the 1.5%, predicted 37, 398, and Z score, C, and person predicted is 95.6, 96.2, and G score is minus 0.3. This is which physiological process best displays observed microbial response. Select one answer. Bronchoscopy, bronchodilator response with reduction in gas velocity. Contraction of famous muscles increases velocity of exhale gases, decreases response, decrease tablet size hyperplasia, increase of physical and greater freely as a learning effect and performance parametry. Now, the last one is the relaxation of airways when muscle, increasing airway caliber. Further history reveals that her asthma symptoms worsen when she has cough and colds. Her mother is very concerned about side effects, particularly while hospital growth sufficient with steroids. You decide to adjust the treatment medication you want to apply the positive side effects to her, and her mother was the appropriate medication choice according to the considered correct side effects from the treatment. Select one answer. Alternate day or petitionol side effects, iatrogenic cushion leaves, combination long-acting, longer-acting steroids, retide, side effects, increased growth velocity. And leukotriene supplement Metallica side effects, severe so nightmares, slow release, slow filing, side effects, bradycardia, stop and remain as in start long-acting, salvatory side effects, increase with crush, sudden death. Answers are, sorry, answers is relax for question number one, relaxation of airway movements and increasing airway caliber. And C is leukotriene with the antimetallic side effects, sleep disturbances, or nightmares. First part of the question test contains knowledge of pharmacology of salbutamol. Assessing bronchial response is one method of determining whether airway muscle is contracted stress. Functional response suggests that there is an airway hyperresponsiveness which could be confirmed using either a metacodine challenge, exercise test, or cold air challenge. The British Thoracic Society asthma guidelines advise bronchodilate responsiveness, uh, peak expiratory flow, variability, or test of bronchial hyperreactivity may be used to confirm diagnosis with the same reservation as in adults. In this scenario, the bronchodilator responsiveness of 9%. 9% is reported as an appropriate cutoff point for a positive test in children. The question requires the candidate to have prior knowledge of salbutamol use to elicit bronchodilatation in the test. While most candidates should be aware of this, possible to answer the question without prior knowledge. As a question refers to bronchodilation, candidates should know that bronchodilation predominantly act on bronchial smooth muscles to increase airway diameter, airway resistance for laminar flow is described by Poisson's equation resistance 8 by length to viscosity of the gas by R raised to power 4. It predicts that air resistance increases more dramatically as the diameter increases. However, most resistance to air flow is offered by the tricky and larger bronchi. This counterintuitive observation is due to the branching of the tracheobronchial tree, which ensures the combined cross-section area of the smallest airway sufficient large to provide very little resistance to flow at the 23rd area generation, which are zero point 0.4 mm in diameter. The total cross-section area is 4 m squared because there are 300 millimeters of this size. In contrast, the tracheal cross-section area is just 370 squared. And corticosteroids do reduce mucus production, but not in the short period of time outlined and would not account for the improvement in EpiPen in just 15 minutes. The first 25-35% expiration will increase the BFR is effort dependent. By contrast, the remaining two-thirds of the flow of the volume curve is largely effort dependent. Once a child makes more than 90% effort, the value of a PV and FCF 5 75 predominantly flow dependent rather than effort dependent, whilst there is often improvement seen between first and second attempts. Attempts are only considered relative to attempts. Three attempts within 10% of each other are achieved. Once a consistent score is achieved by a cooperative child, then you can be sure that the child is getting good at the ABC. The test scenario is unchanged. The further indicator is similar efforts in both pre and post. Bronchodilator efforts, although gas viscosity does influence a resistance algorithm, does not significantly after gas viscosity increases airflow can be achieved by using a mixture of helium and oxygen. Helium oxygen mixture can be used in severe and airway obstructions. Second part of the question is to test determines knowledge of possible side effects of asthma medication. Following the introduction, LABA was associated with sudden death in children over 12 and adults with asthma, but this is only in the context of using a LABA without ICS. In here, cortisol described as a concern it would be inappropriate to stop her response, stop her inhaled steroids because rather than cause death alone. This is very, very important to know. This child has fully controlled symptomatic asthma and significant bronchial response confirms diagnosis of asthma. Therefore, careful reassurance about the known effect of low zone corticosteroids required versus placebo. Inhaled glucosinide results in 1.2 centimeter loss in adult height. If the larva is used, then it's important to ensure that inhaled corticosteroids are continued. One way to ensure this is a combination inhaler. All of the other options would be likely to improve asthma control. However, the great side effects from STEM BND are incorrect. Inhaled steroids decreases growth velocity and phosphodiesterase inhibitors such as C1 causes tachycardia, not bradycardia. Because the candidate only really has a choice between leukotriene or alternate day corticosteroids. High leukotriene levels have been found in patient asthma. Cysteine leukotriene C4E4 at derived from arachidonic acid with the help of enzyme 5 like oxygenase. This inflammatory pathway is not modified by corticosteroid, hence the scientific basis for the use of LTR. Cysteine leukotrienes increase glucose production, non-cystic acetylcholine and oxidation of plasma, all being inflammatory processes. Cysteine LTR is mortality causes the only one licensed for use in children have been shown modify the blood processes. Advantages of botrytic acid that it is once daily medication as a granule form for use in the 6 to 24 months of age or as a pink chewy cherry flavored tablet in oral use. It is effective in allergic asthma and vaccine induced these in some young children. While this is a valuable treatment and frequently well tolerated, easy to administer, it is important to be aware of the two common side effects, sleep disturbance and increased thirst. Upon initiation, parents must be informed about possible side effects. Corticosteroid pass through the cell membrane of non-inflammatory cells and structure cells within the lung, followed by infusion with cytoplasm and keratosis and glucocorticoid receptors and form complexes, which then translocate into the cell nucleus. Here, they bind to specific genes involved in inflammation, resulting in increased transcription of genes and which suppress and reduce transcription those which enhance airway function by non-genomic processes. They may also inhibit inflammatory factors such as nucleic factor kappa B and FKB activated protein. Non-corticosteroids are clinically very useful as a reverse airway hyperactivity, a process which takes place within epithelial cells and which, if not treated early, leads to chronic inflammation, subsequent permanent remodeling. And the airways are process which is non-noticeable produces fixed airways, whilst alternate day steroids are highly likely to affect side effects are also very likely, particularly when used to for more than a few days. These include weight gain, muscle weakness, abnormal fat deposition, stria, active osteoporosis, hypertension, glaucoma, cataracts, significant reduction in growth velocity in childhood. Further details about the physiological and also long-term oral steroids can be found in Chapter 14 will do later. Respiratory medicine in ENT. Military syllabus mapping to be able to interpret and select appropriate respiratory investigation, blood gas, spirometry, and understand the pharmacological agents, which is basically pharma. So that is all. Thank you in science. Thank you very much.